Welcome to another episode of What Did the Patient Say with Doctors Dana and Lauren Brindisi, sisters and owners of Carolina Functional Neurology Center. We are providing you answers to frequently asked questions and bringing you inside information from real conversations we have with patients on a daily basis. Our goal is to spread the truth on health and healing because we believe everyone deserves to know the answers.
Hi, everyone. Welcome back to another episode of What Did the Patient Say? You are here with me, Dr. Lauren Brindisi, and I'm also here with Dr. Bianca Moret. And today we will be talking about movement disorders. So I think this was a pretty cool time for us to be able to talk about this. We just got back from a Carrick Institute seminar where he actually touched a lot on movement disorders, on the different pathways in the brain that are required for the development of movement. And then we started talking about what can actually happen when those pathways aren't working efficiently, what types of changes in movement people might develop, and then how that translates when we see people who actually have diagnoses. And then we were looking and evaluating the anatomy associated with that. So I feel like this is a good time. We're kind of primed and ready to be talking about movement disorders. So this is something that we do see in our practices. And we want to touch on the types of movement disorders that we see, what movement disorders are, how we evaluate for them, and what types of treatment we may do. So Dr. Moret, thanks for being on with me. Why don't you tell our audience about, just give us, a definition of movement disorders.
Yeah. Morning, everyone. So movement disorders, there are so many different types of movement disorders, but really when it kind of boils down to it, this is when someone is having an unwanted movement happen through what should be a normal movement. So meaning like if they are walking and they're having an aberrant movement on top of that, or if they're reaching for something and, we all know about tremors, right? That's something that people are usually commonly aware of. If they have a tremor, that's an excess of movement. So as like you're reaching for, your TV remote, it's not such a smooth movement anymore. You're having excess movements. And this can manifest differently. This can be something as I don't want to say simple, but as small as like a hand tremor to like a head tremor to full body, very aggressive movement. So it's definitely a spectrum of what this could look like for individuals.
Yeah, it's as simple as that. You have a movement disorder, you have some change in your movement that is not normal. And as clinicians, when we have people come in with movement disorders, whether they have a diagnosis or not, we still want to look in a lot of detail about what types of changes in their movement that they have. So is the movement too slow? Is the movement too fast? If they have a tremor, what hertz is that tremor at? And that's something that Professor Carrick touched on. And I always appreciate that because I feel like sometimes I get used to thinking about it as the type of diagnosis, but for us as clinicians, it can be really helpful to break down what hertz that tremor is actually at, and then where are they experiencing the tremor, and then are they experiencing the tremor at rest or when they're actually moving? And so all of those pieces help us, again, even if someone comes in with a diagnosis, but as we're starting to evaluate these patients and coming up with a treatment plan that's individualized for their needs, right? This is a lot of, if you're someone who's seen our podcast before, this is a lot of what we talk about, no matter what diagnosis you have. As functional neurologists, we want to take that one step further to say, okay, we know that you've been diagnosed with this movement disorder, but let's look at this in terms of how is that movement disorder affecting you? And how can we even better triangulate the areas of the brain that might be affected for you? Like I said before, these are pathways in the brain that get affected. It's not necessarily one specific area. And we can look in even more detail of how is that pathway being affected. And that might look a little different from one person to the next. So Dr. Moret, tell us a little bit about the common types of movement disorders that we see.
Yeah. I mean, we see everything from essential tremors, which is movement, like you're usually manifesting in the hands to start. And it's a very, very quick tremor. It's very subtle. And for people who don't know, at baseline, everyone has a tremor. So great way to do this is if you bring your hands out and put a sheet of paper over your hands, you'll see the paper shake. No one is completely still. And the brain's job is to inhibit everything, to inhibit movement, to inhibit thoughts, to inhibit emotions. And so when we're talking about functional movement disorders, this is when the brain is not properly inhibiting movement, but everyone has a tremor at rest. So, one of them is an essential tremor. Some of them are Parkinsonian tremors. So this is individuals with Parkinson's disease. We'll see functional movement, functional neurological disorders where someone may have aberrant and very ballistic hand movements that they actually don't know. They may not fit into certain criteria for very specific types of movement disorders. And they're like, I have all these tremors, I have all these muscle contractions, I don't know what's going on. We see a lot of dystonia, which is like a part of the body that is like a torticollis, where the neck is stuck into a certain position. This is a type of dystonia, and you can see dystonia not just in the neck, but in other regions of the body, like a limb or like an ankle, hand, stuff like that. So we'll see those. We see everything from, see if I'm missing anything.
I think those are the big ones.
Like the big ones that we see.
The big ones, yeah.
There's voice tremors actually would be something I would also add that people may not realize, is you can also have vocal cord tremors.
Oh, yeah. Yeah, that's a good one. And then there's subtypes as we look at these different types of movement disorders, which we don't want to go into all of the detail of that.
Yeah.
I think Parkinson's is a big one to really take home because, well, one, personally, I've treated a lot of patients with Parkinson's and I do enjoy it. And I think, looking at Parkinson's and understanding that this is a degenerative disorder and it takes a lot of time for the development of Parkinson's.
Yeah.
But what's very interesting is as we start doing treatment, there's still vitality left in the system, even in some of the worst cases. So it's just really been so humbling, and it does sometimes blow my mind that, I have a patient who can barely talk, barely walk, has 2 deep brain stimulators. His balance is so bad. And that was one of the reasons that this patient came in. He didn't have the ability to stop himself from falling backward, which is obviously extremely dangerous. You're at risk for hitting your head, and that could just be catastrophic for somebody in these situations. And we were able to use different neurological strategies, specifically talking about like optokinetics. So actually using stripes in his field of vision that we were able to use to start to change his perception of his center of pressure and actually shift it so that he was able to, one, initiate movement better. And then he actually had the capability of kicking in some of those reflexive mechanisms that would stop him from falling backward.
Yeah, that's awesome.
Yeah.
I love that. Yeah, with Parkinson's, we can talk about kind of like how that manifests, like so that people know, because everyone thinks of Parkinson's as like a hand tremor. But yeah, even metabolic reasons we can have tremors appear. I've had patients that don't fit the criteria for a lot of movement disorders, and there's been a lot of new research coming out that shows like there's something called like gluten ataxia and the way your cerebellum works, and it's stemming from a gluten intolerance. And now this is not for everyone, and this doesn't apply to everyone, but it can manifest as tremors. And that's usually sometimes the first sign of it because of all the maladaptation that the brain undergoes as this disease process is taking place. And then finally we see the tremor, and we're realizing that they're not fitting certain criteria for like a Parkinson's or like an essential tremor or different types, but it's actually stemming from a metabolic reason that the brain is behaving this way after years and years of neuroinflammation and like what the immune system has done and its relationship with the brain. So we take that one step further, not only looking at the disease progression as itself and like where the areas of the brain it's affecting, but also what are some metabolic reasons that this may be happening, like, you know, the area of the brain where tremors and movement disorders stem from. Some of them is your basal ganglia, and this is the area that's most sensitive to metals and metal exposure. This area is extremely sensitive to that. So, you know, and co-infections. And like, so we keep that in the back pocket when we're dealing with these patients too, is there anything that goes beyond just the neurology that's in the outside world affecting the body?
Yeah, I think that's a good one to bring up, the gluten ataxia, because these patients will come in and can come in, while it's not a extremely common thing that we see, but generally they can be very young and they're coming in with pretty significant clinical observations of, you know, changes in their movement that you would expect to see in somebody a bit older. So generally, if I see that, I mean, that's a really big red flag. Unless they have something maybe structural or congenital that could have also been causing this. So those are things we haven't really touched on today, but there's other reasons that people can develop changes in their movement, in their gait, in their dexterity, that also could be related to neurodevelopment. But if they don't have those things going on and they're young, that's like one of the first things that comes to my brain is I'm going to test them. Do they have celiac disease? Are they creating antibodies to their cerebellum? Like, what is going on there? Because this completely doesn't make sense. And that's a wild one to think about. Mm-hmm. That something, that food that we're consuming could be causing such significant symptoms for people. And I agree. I think environmental toxins is a really big one, especially when we're talking about Parkinson's. As we start to better understand the development and the progression of Parkinson's, I mean, it's 20, 30 years before somebody actually develops a hand tremor, that the process has been going on in the brain. And we understand that some of the first places that are affected before a change in movement is actually in the olfactory bulb. So you're changing your sense of smell, and then the motility of your gut. So your digestive tract. And there's a lot of studies that have come out talking about what's going on in the overall health and environment of the digestive tract and how that may play a role, like you said, infections and things like that in the development of Parkinson's disease. I thought it was very interesting this weekend. Professor Carrick gave a stat that I didn't know. He said only 10% of Parkinson's patients are genetic, meaning that the other 90% develop just due to our environmental exposure and what may happen to our brain in that degenerative process. I thought that was fascinating. I didn't know that.
I didn't know that either until he said that. It was pretty amazing. And that tremor that you see is 15 years in the making. And so we kind of associate Parkinson's with, like, you know, as we age, when in actuality it's.
Oh, we lost her for a moment. I think she'll pop back on in a second, but as we move through our understanding of movement disorders, like we said, we want to investigate that. Hey, welcome back. That's okay. We can't hear you. I was just going to keep moving and talk a little bit about what we do in terms of treatment. So, okay, we can hear you. So, Dr. Moretta, if you want to talk a little bit about, you know, you touched a little bit on what are some of the areas of the brain that generally get affected in movement disorders. And then let's talk a little bit about what some things we do for treatment for patients.
Yeah, one of my first approaches with a movement disorder is, can I attenuate the movement, the aberrant movement on the spot? Can I change it? Like, and that's so, you know, through my exam, that's what I'm looking to do. And what does their system respond best to? And so there's always a way in. That's the beauty of what we do, is there is a way in. It's just a matter of how much can that nervous system and that brain handle. So that's like one of my first approaches. So if someone is having, more of cerebellar movement disorders, which this looks more like an intention tremor. So meaning as you move, and then at that end range of motion, they're starting to get, that aberrant hand movement or through their feet. And that can manifest differently. We can try, something I do is I'll try to drive cerebellar function, right? And your cerebellum loves vibration. It loves, specific complex movements. It loves certain things. So it loves imagery. So there's things that I will do and have the patient do either, on that exam and through treatment to help drive that. If we're talking about, your case with the person with such a far posterior center of pressure that they're always falling backwards, and we need to drive that center of pressure forward. That's mitigated in obviously using like more reflexogenic systems like the OPKs, but also, the frontal lobe. So doing more of those cognitive tasks, if the person can do it, that could be using feedback with balance, right? So you're putting them on a balance plate and they're watching a screen and it's showing them where they are in space on the screen, so that they're getting direct feedback as to where they are. Again, the brain loves vibration. It's a very quick modality up to the brain. So I'll use a lot of that. Red light, definitely, if I'm thinking there's more, an inflammatory process, but also these neurological cases, these these disordered movement cases are sometimes very fragile, and their brain really needs a lot of help from a metabolic standpoint to create ATP in order to create neuroplasticity. So using red light, using the hyperbaric chamber is something that is definitely extremely effective, especially for like degeneration types of movement disorders. So there's so many tools we can use, but my main goal is, can I change this movement? Can I make it smoother? Can I attenuate it on the spot? So again, I think recently I used mirroring. So I brought a mirror up and they were watching their hand that wasn't tremoring, and their other hand stopped. And it's like, great. Like their body was receptive to that modality. So that was really cool to see.
Yeah, I think that's one of the things personally as a clinician that I really enjoy about treating patients with movement disorders, is that the symptom that they're experiencing is very easy to observe. And so for us, the way that the brain is able to change and adapt, if we provide it the right stimulus, can happen almost instantaneously. Now, that doesn't mean that that's lasting. And what Dr. Moret means by attenuate is, can I give it the brain some kind of stimulus, and for a moment, can I observe a change in the frequency, the amplitude of the tremor or of the aberrant movement, if you're watching someone walk or whatever that looks like. And we can see that in real time happen. So we can observe their changes in their movement, we can provide a therapy, and then we can watch it change. And we have a temporary moment in time to be like, okay, this worked. So now we're going to use repetition to continue to fire those pathways and exercise them. And that's really what we do with our patients across the board. But there's just something so magnificent, I feel like, about seeing it in real time with a change in someone's movement, because it's something that everybody can observe. You can see those changes whether you're trained or not.
Yeah, it's really cool. I'm remembering one case, they had a blepharospasm, which is a excess movement in the eyelid. So they had chronic blinking, and it was to the point that they couldn't even see anymore because they would just blink, 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 blink. And what really did it for them was I put them in colored lenses, and you could see their eyes open, and still a little bit of that movement would appear, but a huge difference. They could actually like maneuver around the world again and open their eyes. And they were like, oh, I can actually see you. I didn't know you had brown hair. Like they didn't know what I looked like because they couldn't see me. So it was really neat to see them go, whoa. So that's like, I agree. It's just so cool to see that change like instantaneously. And again, not lasting, but over, frequency, repetition, and timing, which is, the beginning fundamentals of neuroplasticity, we can see that change and improve on significantly. Yeah.
Well, I think we've touched on a lot of information, so don't want to
Yeah.
overload everybody, but we do love talking about these things. We enjoy talking about all types of neurological conditions. So if you guys do have any questions about movement disorders specifically, or if there's anything else that you guys would like us to touch on in more detail, or you have something else you would like us to touch on, you guys are driving the content that we are creating. So please like, share, comment, DM us, just let us know. We are here to help. So thank you, Dr. Perrett, for being here with me this morning before patients to get this information out to people.
Thank you.
Have a good day.
You too.
Bye.